We want to thank all of you for attending live and to our panelists and also to our host, NextGate, for putting this all together and bringing us together to have this discussion. If you're following along for the live discussion, be sure to tweet any insights, questions, perspectives, added insights on Twitter. Use the hashtag HITSM, and also HIMSS20 is also another great one you can throw in there. And be sure to mention at NextGate, and they'll take a look at your comments and reply and can help also with any questions or comments that you might have. All right, I think that's enough housekeeping for now. I want to go around and introduce all of our panelists. We're going to have them each introduce themselves briefly. So we'll go around the room introducing themselves. So Julie, you want to start?
Sure, thanks, John. Name is Julie Dooling. I'm a director with the American Health Information Management Association, AHIMA. I actually started my career a few years ago working with the MPI and patient identification and matching, and I certainly won't tell you what kind of technology I used back then to remediate duplicates, but this has been a passion topic for me for many years. I've worked on this topic here at AHIMA for a few years, and I've also worked on the topic working for a national MPI cleanup service as a consultant. So appreciate being here. Thank you.
Thanks. We look forward to your insights, Julie. Dan, you want to go next?
Sure, John. So my name is Daniel Cidon. I'm the Chief Tinkering Officer of NextGate, or Chief Technology Officer, depends what you want to call me. But involved really on a lot of the software development side of what we do at NextGate, and certainly we understand at NextGate just how important this space of patient identity, as we've been working at it for close to 20 years. It's still a very challenging area, one that's very important, very fundamental to the kinds of initiatives that many organizations are trying to achieve. Really, you have to master your patient identity before anything else can be effectively done. So looking forward to this discussion. The National Patient Identifier has been kind of on and off for many years, a topic of interest to people, and definitely would like to share our perspective on it.
Thanks, Dan. I'm excited. This is the second one I've done with Dan over the years, and I've always learned from you in all the meetups we've done. So thanks, Dan. Mark, you want to go next?
Sure. Mark Segal. I'm principal at Digital Health Policy Advisors. I do digital health policy consulting with a particular focus on interoperability, the various payment incentive programs, and patient safety. Prior to this role, I was a vice president for Government Industry Affairs for GE Healthcare Digital. In my career, I've really seen the critical importance of patient matching within organizations, within hospitals, especially across healthcare organizations in terms of interoperability, and especially critical, and it's something that I think everyone here is focused on, the patient safety really impetus to get matching correctly. So I'm also very excited to be here today and looking forward to our meetup.
Thanks, Mark. I still remember the early days talking meaningful use for you and learning from all your insights. So
including at many HIMSS.
Great to have you here. Yeah. Many HIMSS, in fact. All right, Ben, you want to wrap us up?
Yeah, thanks very much for including us. My name is Ben Moscovitch. I direct the health IT work at the Pew Charitable Trust. For those that don't know Pew, we're a large research and public policy nonprofit, and we've spent a few years researching different opportunities to improve patient matching, ranging from data standardization to unique IDs and biometrics. You name it, we looked at it, came out with a series of recommendations, and now are continuing the work in this space. I really look forward to this conversation.
Excellent. Great, Ben, and thanks for all of our panelists. Also, if you're watching live, if you have any questions, you can submit any questions through the GoToWebinar screen as well. So feel free to submit those. We'll do everything we can to incorporate the questions within the discussion. So let's start off with, maybe the easiest question of all, but according to a new EHI and NextGate survey on patient matching, 70% of US provider and HIE professionals agreed, at least to some degree, that a national patient identifier would help to improve patient matching rates, which is shouldn't be any surprise for most of us watching. But is a national patient identifier the answer to our patient identification problems? Dan, you want to start off with that?
Oh, okay. Well, I think it's certainly a helpful step towards that. I'm not surprised about how many organizations are seeking that kind of an identifier, because really they have been suffering with duplication and fragmentation of data for decades, and they understand, at least the concept of having a single ID to tie everything together is really a logical approach. The thing is that we've seen other countries attempt to roll out these sorts of universal identifiers in health, and namely, we've done a lot of work in England, and in fact now in Scotland, we're replacing their system that is giving the identifiers for all of the citizens of or residents of Scotland. So we understand that those kinds of systems do work to some extent. I mean, certainly the identification problem that we see in countries that have implemented an identifier of that sort has, definitely improved the situation with how we identify patients. But we still see that there are a lot of systems that are not able to communicate that identifier, that the patients themselves don't know the identifier, that foreigners that kind of come in and out of the country over the years get new identifiers. So it helps, but it tends to kind of push the problem to a different place. So if you think of like plumbing in the wall, you have a leak somewhere, you fill that leak, and then somewhere up, higher up in the pipes, there's another leak. The situation in a complex environment like in the United States is that our plumbing can't really handle trying to push everything into some sort of a central point, because if the management issues of a national identifier are difficult in countries like England, smaller countries like Scotland, then I can only imagine that there would be a lot of bureaucracy and a lot of complexity around managing that in the United States. So there's a lot more that could be said, and maybe we'll touch upon it when it comes to things like privacy and the ability to kind of segment who's able to see what, and how much do you really allow people to tie information together. That's a whole other area, but maybe we'll get to those topics. I don't want to take up too much time on it.
Yeah, definitely. And unfortunately, this is probably a 3-day discussion, but we have 45 minutes. So did Scotland go from no patient identifier to a patient identifier, or
Well,
did they go from
no,
an old patient identifier to a new one?
they really have to give them a lot of credit that I think it was close to 30 years ago or more even. They implemented what they call their community health identifier, which is essentially like their NHS number. And they did this on an old mainframe system that they're just now in 2020 looking to replace. So it's really quite extraordinary that they implemented this so much earlier on than the United States or other developed countries. So yeah, they're just looking to kind of refresh the technology because the mainframe is ancient.
Makes sense. Ben, any thoughts on this and extensions to what Dan said?
Yeah, 100% agree with Dan. One of the things we did was we did focus groups with patients around the country to understand their perspectives on patient matching and their perspectives on unique identifiers. And one of the things we heard from a lot of patients was that they use their finger or their face to unlock their phone every day, or board an airplane, or go to Disney World. And so are there ways to use those same type of approaches, biometrics, to be solving this problem of identification and matching? There's a lot of technical challenges to using biometrics for matching. There's a lot of privacy challenges that need to be addressed. And so one of the things that we're doing is we're examining 10 different biometric implementations around the world and in different industries to see if we can identify lessons learned for healthcare, and then try to build out a framework that would be that could use biometrics in a technical manner in the U.S. healthcare system for matching across organizations, while also preserving privacy. And that's going to be challenging, and we really look forward to continuing that work.
Oh, that's great. And maybe we can go to Julie and kind of extend this conversation, because I think most of the people here agree that it's not a cure-all, but it is beneficial and it is something we should do. But let's say that the US actually implemented it. They slipped it into some coronavirus coverage or something, some legislation, that could get it through or something quickly. What would be the next steps for, I mean, you come from an organization like AHIMA that would be at the core of implementing this type of solution and using the identifier. What would we do if that were to happen, and what's the best approach to rolling it out?
I think that we could literally just start anywhere. You know, we haven't been able to talk about this for 20 years. Imagine not having the ability to speak to one of our biggest payers in the United States certainly doesn't put us in the position of being able to affect change or to have the discussion about having a nationwide unique patient identifier strategy. So I think it's yet to be determined. I think if, you know, we are certainly on the Hill, we are advocating for the federal language to be struck from Section 510, which is the fiscal year 2021 appropriations bill. And I don't know where we would start, but the point is that it could be a UPI, it could not be a UPI. We don't know until we can freely discuss and come up with a strategy. And I think, you know, as you are free to do that, I think innovation will come in if you're able to freely talk about it and work with our industry and governmental partners. I think innovation will show us something new that maybe we don't know right now.
So let's, you know, loop Mark in as well on this, because you spend a lot of time in Washington and talking to the politicians around this type of policy. I've heard that the reason we couldn't do it was because of privacy fears, that they're afraid that having a national patient identifier will somehow inhibit privacy. Is that what's still blocking it today, or are there other things that you see that really need to be done in order for a national patient identifier to become a reality?
Well, I think that the privacy concerns are certainly there and embedded in the legislation that Julie mentioned that's been around for some time. And I think that those are real. But I think the larger issues, and I think my colleagues here all touched on them, is just the sort of the enormity of rolling out a new identifier. You know, we've seen that. And then the issue of whether a new identifier, as Dan was saying, and Ben as well, is whether that's really sufficient, and whether it's the silver bullet. And so, you know, I tend to think that the advantage of beginning to loosen the restriction, including some of the language that was in the appropriations bill that was passed late last year, that actually, I think, beneficially does two things. It says that the prohibition on doing an identifier doesn't restrict ONC from providing technical support, but I believe it also calls for them to do a report to Congress that specifically considers an identifier, which is a huge move forward, and I know AHIMA and other groups had a big role in there. But that what we really need to be increasingly focusing on is the need for accurate identification, with that ability, as Julie said, to consider the full range of options. And I think an additional thing that often isn't addressed or recognized is that, you know, in the jargon we all live with, there's no one use case here. And so there are needs that a hospital, for example, has within its own environment to link patients who may come at, you know, at different times, to make sure that patients with the same name aren't duplicated, to deal with data that are, you know, across their systems. But then you also have the use cases around interoperability as you move across organizations. And a new use case that is really getting a lot of focus, particularly with the regulations that just came out, is accurate identification of patients for apps accessed through APIs. And so it's unlikely that exactly the same solution, you know, a single national identifier, is going to be the appropriate solution for all of those. But again, what's critical is that we can have a full discussion considering all of the options.
I like it. So Ben, we've got a question that you may even, you know, I know Dan already kind of addressed it to some extent, but I wonder if you've done any work on it. The audience asked, what might the cost and time frame be for implementing a universal identifier? Obviously, it's a little bit of, you know, hard to predict considering the complexity of healthcare. But have you ever done any work or any thoughts around what the cost and time frame might be?
Yeah, so as part of our research on this, we looked at a lot of documents documents on it. I don't remember the exact number, but at one point CMS did estimate the cost, and it was fairly expensive. And I'm happy to to pull up that number and share, and you can share it with the panelists at another time. And as I think Mark mentioned, or impressed Julie, rolling out a national ID would take a long time to establish what the standard is for it, to then ensure that patients have it, that's embedded in EHRs and so forth. There are steps that ONC can and the federal government can be taking today, absent legislation, to advance patient matching. And we actually saw ONC do some of this in the rule that was issued on Monday. What ONC did specifically was, as part of the API requirements that Mark mentioned, they added new data elements that could be used for matching. The proposed rule included address and phone number, but then the final rule included additional data elements, notably the patient's previous address and the patient's email address. Those are important data elements that can now increasingly be used for matching in a way that previously they would not have been once the rules do take effect.
And just real quickly to add on to what Ben was saying, what's also notable is that in defining those particular data elements, ONC also identified the particular standards that would be used to create them, so that you have consistent formats, consistent standards for those data elements, which I think multiple organizations have identified as critical.
Yeah, and I'll
That's
just
right.
chime in and say, I'm sorry, go ahead.
Go ahead, Julie, and then we'll come to Ben.
I was just going to chime in and say I think the US CDI data elements are a good place to start. I'm happy that they did add those additional elements in the final rule, Ben, as you said. I do think that we will see an opportunity for other data elements to be added to that over time. I know that one of the areas that our members struggle with in managing the MPI right now is the data elements surrounding sexual orientation and gender identity, which some of our EHR vendors have taken the lead on that and have included data elements like preferred name and legal name and that sort of thing. So I do think it's a good start, and I think that it'll be a place where we can add to as we go along.
Yeah, I agree, and I think on the standards piece, there was an interesting discussion in the first part of the rule about standards for patient matching, and as Mark said, they added a standard for phone number. What they didn't do was add a standard for address. So there is a U.S. Postal Service format for address that approximately 24 organizations had called for ONC to require as part of the rule. Our research has found that if you use the USPS format for address, it can improve match rates approximately 3%, like from 85 to 88% when sharing data with other organizations. And for those that aren't familiar with the USPS format, it's essentially when you go online and try to buy something and the website slightly changes the address. Typically that's because it's being put into the USPS format. That's an important step that ONC can and should be taking in the future. And the Trusted Exchange Framework might be a great opportunity for ONC to further accelerate the use of that standard.
Excellent. So a lot of options, available, and I love the idea that there are some existing standards that we can use even today without the National Patient Identifier. Dan, maybe we can come to you and kind of shift the conversation a little, because the National Patient Identifier still leaves lots of things, lots of challenges, and you talked about some of them before, but what are some of the problems that still exist even if a National Patient Identifier was introduced, and what are some of the solutions available for those problems?
Yeah, it's a good question, because a lot of people think of a master patient index, like the software that we provide, as just providing an ID, but actually what you have with that is a platform to reconcile the data that you have from multiple systems that have their own essentially silos of demographic information. So, while a unique patient identifier can help with the linkage problem to some extent, it doesn't help with the fact that many different systems have essentially outdated or incorrect information about you from the perspective of demographics, and that can have like a real impact when it comes to even clinical aspects. In case, for example, you have a transposed date of birth and they think that you're 70 years old as opposed to 17 or something. So, you know, the UPI is certainly, I mean, we would tend to look at it kind of like, in some ways, and I hate to use this as an example, but everyone understands it, the Social Security number, which increasingly we don't use because organizations are not transmitting it, you know, in their message stream. But when they were, it was, you know, to some extent a useful identifier to aid in the matching. That's essentially what the UPI, you know, would be for us. But it still leaves the entire questions around the data quality at the underlying sources. You know, it doesn't really address that, and there is a need to always, for organizations to always keep an eye on their data governance and how they're managing the capture of that information so that it's consistent. I'll just say one other thing, and that's to build upon what Ben was saying around the postal service, or the postal service format. You know, the address information is really an important category of data attribute when it comes to demographics, because not only is it important for the purposes of matching, but when it comes to communicating with patients, whether it's for billing or sending things to them, to a patient, or understanding what households patients you know, reside in, address information, a cleansed version of address information that is to a standard and is also ideally also geocoded, has tremendous value. So, and these are all things that go beyond simply just having a universal patient identifier.
I've even heard people say cell phone is becoming the universal patient identifier
Yeah,
as well.
indeed.
Are you using that or
Yeah.
any of those techniques, or what are the challenges there?
It suggests to me, yeah, I think that certainly that is in some ways becoming the universal ID, and it also has the added benefit that it's a communication mechanism. It's a way that
Yeah.
you can text people appointments or you know, have a dialogue with a provider, is just through the phone number itself. So yeah, certainly there's a lot of truth in the statement that that's becoming kind of the de facto patient identifier, or not just patient, but, you know, across industries.
Yeah, we love our number, Ben. It looked like you had some ideas too.
Yeah, and in the proposed rule, they also specify the phone number type as part of the APIs, which wasn't in, you know, previous regulation. So that'll be important to understand whether the phone number in the record is a home phone, work phone, cell phone, etc.
Yeah, and this is Mark. Just one thing I'd like to sort of add, building on what Dan was saying, is the importance, recognizing this is not just a technology solution, that the underlying data, and something that AHIMA has worked on very heavily, data governance. There have been really good best practices that have recently been put out to organizations that I've worked with. ECRI, as well as the Sequoia project, have developed guidance that's relevant both within organizations, and the Sequoia project really focused on best practices, a lot of it around data quality for a cross-organization exchange. And the recognition that even where you have an EMPI or other technology solutions, that there's an important role for multiple stakeholders, you know, particularly at the hospital or healthcare organization, and even clinicians. And this can start with, you know, patient registration all the way through, you know, the processes that you use to determine what data elements you're going to collect and what kind of quality control. So this is really a multifaceted problem, and one that goes really beyond, you know, fancy technology to sort of nuts and bolts data quality and data integrity.
Absolutely, absolutely. So, you know, we talk about often in our publications the phrase people, process, and technology. And technology is one piece of it, but it certainly at this point in time is not the silver bullet. It's not going to fix all of our patient matching woes. There has to be a consolidated collaboration and cross-functional team approach in patient matching. It's not just an HIM problem. It's not an IT problem. It's not a patient access or a registration problem. It's our problem. It's our problems as a patient and our problem as an organization. And so when you bring those three areas together where you have, registration, registering the patient, attaching a number at that point, some of our members have expressed that they would like to see more patient matching solutions up front in our registration systems, because that's where a lot of those errors are being had. If you had a conversation with your EHR vendor today, you could say, this is what I need. I need better search algorithms up front. I need the ability to tune my algorithms on the back end. So it's about all three of those areas: people, process, and technology. It's about the data integrity teams coming together, where we've seen it work best is in a centralized manner, where all of the errors are being addressed in one place, where if you're going to change a name or a date of birth for somebody, it's happening in one place instead of multiple areas where there could be more errors done. So couldn't agree with you more, Mark.
Definitely, and it seems like the only silver bullet here is hard work and communication. So the other things that people don't want to really do. Ben, are there other things? So I mean, and we know that a national patient ID would improve some things. Are there other things that organizations should be doing to deal with this patient matching, patient identification problem? Are there biometrics? What about referential matching? Any sort of data standardization? What other things do you see as, okay, here's my list of what would be really valuable in this area?
Yeah, so definitely the short term, as you mentioned, is additional standards like USPS for address, and additional data like email address and several others, and including the ones that Julie mentioned. Second, you mentioned referential matching. Certainly, anecdotally, we've heard that offers promise. There are some limitations, and organizations should kind of evaluate whether that's the appropriate tool for their patients. In terms of biometrics, it's really important to talk about the use case when we talk about biometrics, because biometrics are used today in healthcare for identification. There are facilities that, for example, you can walk in and they use your fingerprint or your palm scan to pull up the right record. That's not the use case that we here at Pew are most focused on. We're most focused on the provider-to-provider exchange of records. So, hospitals that aren't affiliated with one another, for example, trying to coordinate care for that patient because that patient wants their care coordinated. How can you then use a biometric to do that? The way biometrics are stored in records or can be stored often may not be transferable or interoperable with a similar biometric in another facility. And so those are the type of challenges that we're working through, and we hope to have some recommendations out next year or the year after.
What are you seeing with this, Dan? You work with a lot of these organizations that do facilitate this type of communication, organization to organization. Can you do that with biometrics, or what are some of the best practices there? Because it seems like the push to interoperability is on. Mark talked about that before. The legislation clearly says we need to start sharing this data. How are organizations going to approach that without just blowing up their patient matching and patient identity problem?
Yeah. I mean, we kind of look at it like Ben does in terms of short-term and longer-term initiatives. I think in the short term, the emphasis in our software has always been around being able to use historical data elements and now also referential data to make up for some of the gaps that make it difficult to match, on the basis of demographics. We do encourage in all of our implementations, as everyone's been discussing, the capture of additional information, such as things like phone numbers and prior addresses and prior names and all of that. And with that, we can achieve a very, very high level of accuracy. But having said that, it's clearly not 100%. And any sort of a system that is based on this kind of fuzzy matching of relatively loosely entered pieces of information is going to suffer from something less than 100%. So, longer term, there's little doubt in our minds that where identity management will be heading, both for patients and providers, is in the use of mobile applications. So, in the last 10 years, really, it's become almost ubiquitous that everyone has some sort of a handheld device, if not a wearable device. And those devices have, in fact, biometrics built into them. And I didn't really touch much upon the short-term usage of biometrics, because we've seen a lot of the challenges that Ben was describing in terms of being able to transfer from one facility that uses one technology to another. But what we have, at least with the mobile technology, is biometrics built in, and basically something that unlocks your phone. And by unlocking your phone, then it has the ability to unlock digital credentials that you may carry on your phone. And we're seeing the beginnings of digital identity appearing, not necessarily in the health space, but for example, you can go in the driver's license, get your driver's license, and also get a digital driver's license, I believe in California. And those credentials are stored basically within a digital wallet. So that's a space that we're watching carefully, and we're doing some initial work in, because that, I think, in the next 10 or 15 years, if anything, would really enable a big leap in the ability to accurately match records together, and also, by the way, deal with issues around privacy in terms of how much information is divulged when those credentials are used, those digital credentials.
That's great. Well, Mark, do you want to chime in on this? And maybe let's extend the conversation to EHR vendors as well.
Right.
And what's their role, since they are central to much of the healthcare data?
Right.
I know you've been with the EHR Association for
Right.
many years. You were a voice there. You worked at an EHR vendor. So what's their role? And feel free to chime in on also the
Sure.
solutions available.
So, I think a few roles. One is in and something I know, Ben and Pew have worked on a lot in terms of usability, in terms of the user interface for how you collect the data on the patients, how you verify a patient's identity, when they're presenting. We've all seen as patients where, we often have, steps taken, they ask your birthday, they'll often have a photo, right, with your record, small but really powerful things like that. So one is sort of user interface. The other is making sure that the data, the right data elements are being collected and then are usable, whether it's for health information exchange, whether for access for EMPIs, things of that sort, whether you're using the appropriate standards, what kind of tools you have to help your clients basically improve data quality. So all of that becomes quite important, as well as the discussions or the decisions to be made about what kinds of technologies you're going to use for matching. Are you going to have your own algorithms? Are you going to work with a company like Dan's in terms of an EMPI? So it's really what it gets down to, and it's always this, and it's kind of hammered into you in that world, is you need to understand your users' needs. You need to understand them very well, and then you need to basically help to design solutions where your technology is part of a broader set of solutions. Well, one other thing that I'd love to kind of throw in, as I mentioned, there are a lot of use cases here and needs around matching, and a couple of more recent ones that I think are really critical. One around social determinants of health, where you have organizations that are not really sort of healthcare organizations or necessarily in that world, but the need to make sure that you basically can accurately match patients so you can assess where they are, for example, in terms of social determinants of health and needs. And the second, which is, has privacy and other implications, but is in the news a lot, is the kinds of very large data sets you need for things like artificial intelligence. And the integrity of those data sets, making sure that if you think you're bringing together, multiple data elements on a given patient, that's actually the same patient, that's really foundational to the validity and accuracy of the AI. So, this whole issue of just being able to link across multiple data sets for patients, sort of the needs go on, and I think they'll keep evolving as our uses of data evolve.
Great. Lots of good insights and lots of opportunities. It seems like, Dan, we may need to do a follow-up conversation about all the solutions that aren't National Patient Identifier.
Yeah,
that'd be good.
There's a lot to discuss in this space, absolutely.
For sure. So Julie, maybe you could chime in. I think those that are watching this are probably wondering what should they be doing to help advocate for a national patient ID, and how do they make sure their voice is heard? Any suggestions on things that they could proactively doing to push this forward and to push forward efforts to improve the patient identification space?
An example is our 50 component state associations, who have been very engaged in not only letter and call campaigns through our advocacy center that we have here at AHIMA, but also they've had their own Hill days. So whatever group you're in, volunteer group, if you want to join our group, we'd be happy to have you do that. Just to bring awareness to our representatives and our congressmen about this. I think that there's some confusion out there. I think, just going back to the UPI and the ban, I think that there's still confusion that it's we lift the ban and we get a UPI. Well, that's not necessarily true. It's let's lift the ban so we can at least talk about it. So I think that is really important to know, and when you're advocating for it, but just advocating to lift the ban so we can have a conversation. Any of us that have been in any sort of relationship knows that if you haven't talked to the person for 20 years, odds are you're going to learn a few things, right? So, I mean, there's been a few things that have changed in my life over 20 years. I think it started when my son was 4, and now he's 24, and so I think it's a chance for us to have that conversation and figure out where we're going to go from there. So we're hoping that this fall in the appropriations bill will get lifted. We continue to advocate, and I would welcome anybody to see what we're doing in our advocacy center.
Anything you'd add, Mark or Ben, to what they can do to help the efforts?
Yeah, I think Julie, had it well. I think there's the education. There's really being clear that even lifting the ban does not lead immediately to a decision. We're going to develop and roll out an identifier. It enables a full discussion. And I think a side benefit of the advocacy efforts from organizations like Julie's and Pew and others is it really has elevated and focused the discussion on patient matching generally. And so I think it's had a very powerful side benefit. It's helped shine a light on the work that companies like Dan's is doing in terms of finding innovative solutions, including, and again, it was great what Dan was talking about earlier. We often tend to be sort of parochial in the U.S. and only look at our own experience, but we can learn a lot from how other countries have approached this, and so some of the experience that we've seen in Europe. So I think once you have advocacy, the first step is to establish, well, this is an important issue, and then that really generates a whole series of side benefits beyond just the focus, which is still critical on getting rid of the ban itself.
Sounds good. Well, we have a bunch of questions. Let's see if we can go through a few of them in the last 5 minutes we have. Maybe Ben and Dan could take this first one. Said, how can existing technologies like public key infrastructure and or blockchain be utilized to solve the MPI challenge? You knew a blockchain question had to come, right?
Yeah.
Ben, you want to start, and then Dan, or either way?
Go for it, Ben. Go for it.
I'll pass. It's okay.
You'll pass.
Oh, nice.
Blockchain will solve all the problems, including this virus epidemic, right? No, it's all jokes aside, I think that there has been a lot of noise around blockchain and misunderstanding of what the technology can provide. A lot of people kind of were talking about it as though it's someplace where all sorts of information can be stored, and in that way somehow the truth of that information, by the nature of it being stored there, is assured. But really what blockchain helps with is having essentially proofs of the data stored there, not necessarily the data itself. And the idea is, if you really want portable credentials, then in some ways it makes sense, this whole notion of blockchain, because then you don't have any one central keeper of identity information, being, controlling the entire universe. If you look at spaces around decentralized identity or self-sovereign identity, there are small inroads being done in that space, where the idea is that people should be the keepers of their own identity, and it should be portable, and it can't be stored by one institution. So for example, the example that I like to talk about is, when you, let's just say that you go to a bar or something like that, and you want to show your age, and so you give your driver's license. So the way it works today with the driver's license is that the DMV is not informed every single time that you're going to some particular place, to have a drink. The people are using those credentials in a portable way and not informing the DMV. Now, if you look at other things like, every time that you want to log in, you have to go through Facebook or Google or whatever, that's quite the opposite model, because there, every time that you're logging in to some shop or some other place, some online store, Google is in sense, informed of the fact that some sort of proof of identity is being requested on behalf of this organization. So I think that the blockchain part really plays into that notion of privacy and being able to decentralize where identity information is held. And so it is an area that we're looking at, even though I joke about it, but it's something that has to be talked about in a kind of a nuanced way, because otherwise it causes a lot of confusion.
I mean, what you say is interesting. Another question someone asked was any thoughts about cross-domain matching, and they said an example is healthcare education. Do you guys see any of that in your research, or Ben or Dan or any of you guys? It feels like that's a scary thing that most of us don't want to go to. We have enough to deal with in healthcare.
It's challenging. It's challenging because it takes the issues of privacy and makes it all that much more difficult. I mean, we did see initiatives in England where they wanted to be able to share information with law enforcement and education. So the use case that it was actually in Scotland that they were trying to push for is, if a healthcare professional sees any sort of signs of abuse of a child, they would like to be able to inform law enforcement and to see if there's any sort of suspicious behavior on the law enforcement side that's been detected, or vice versa, have these agencies be able to work with each other. But even with this very kind of limited concept of sharing, not even to the level of saying any specific clinical information, just saying there is some notion of potentially issues of child abuse, even that was causing a big uproar, and they never really got that thing off the ground. So it's a difficult, it makes sense, but it's a difficult thing to institute because of the privacy issues.
Sounds good. Well, let's do one last question around the horn. What would you like to see? Short answer, basically, what's the one thing you'd like that would help improve patient matching? Ladies first, I guess. Julie?
Okay, sounds good. I think the awareness of the people, process, and technology approach in our organizations, that cleaning your MPI is not a yearly thing, it is a daily thing. It is iterative. You have to get in there and work those queues on a daily basis. You have to provide resources and support to those areas. And education, 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 always through the three main areas that take care of it.
Awesome. Dan, what one thing would you like?
If hers is education, 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 mine would be interoperability, interoperability, interoperability. So that there are standards to help EHRs and other applications more effectively communicate and query for patient demographics. We've been attending these events that the IHE holds for a decade now. The amount of support in the industry around interoperability of standards like PICS and PDQ and other types of technical HL7 based standards has been relatively minimal given how long they've been out there. So that would be the one thing that we would love to see more usage of that.
Awesome. Mark?
Yeah, I would say that sort of building a bit on what Dan was talking about, that as we move with some of the work that the federal government and the private sector are pushing around interoperability, data exchange, the new trusted exchange framework, that there is really sort of an accelerated focus on using standards and best practices to ensure that as data are moving, clinical data, patient data are moving around the country, that they're accurately matched. And so that really making sure that patient matching is front and center as some of these new initiatives are launching.
Great. And Ben?
Yeah, I'm with Mark. ONC took a big step forward this week with the final rule on adding email address and previous address. Let's take another big step forward. Add in the USPS standard for address, and even USPS itself can play a role by opening up its API to healthcare.
Excellent. Well, unfortunately, we're out of time. In fact, I think we're a little over time. Dan, any final thoughts?
Well, I just wanted to thank everybody for the discussion. I'm sorry that we couldn't hold it, physically together at HIMSS, but I think this is kind of the new world that, at least for the next few months, we're all going to have to live with, a very virtual world. So again, I just want to thank everybody. I think it was a great discussion. And next time I'll be more prepared for the webcam being on, John. So I'll look dressed up like Ben, at least. I'll look professional. So.
No, I think you look great. That's the new virtual world too, is that we should be more comfortable in our discussions. So thanks everyone for watching. We will send out the recorded version of this video in case you missed it, or in case you want to share it with any of your colleagues. Also, you can check on Twitter, HITSM hashtag, where I'm sure there's a lot of great content and discussion and engagement that happened. And we'll also make it available on healthcareittoday.com, the recorded version, so you can check it out all of these places, and we'll send you the email. A big thank you to everyone that attended, and also to all of our panelists. Thanks, guys.
Thank you.
Thank you.
Thanks, everybody.